to the third podcast in our special edition series to celebrate National Rural Health Day. This three-part series was developed by the Minnesota Rural Health Conference hosts, the Minnesota Department of Health Office of Rural Health and Primary Care, the National Rural Health Resource Center, and the Minnesota Rural Health Association. My name is Nitika Moibi, and I will be your host today. I work at the Department of Health, and I'm pleased to introduce our very special guest today, Teri Fritsma. Teri is a senior workforce researcher at the Health Department, where she studies a wide variety of topics related to the healthcare workforce, such as workforce supply, demand, shortages, etc. Today, we'll be discussing the effects of SARS-CoV-19 on Minnesota's healthcare workforce. Teri will share findings from a survey she recently conducted to understand the impact of this pandemic on the state's healthcare providers. Teri, thank you for joining us today.
Thanks for having me.
So to start us out, can you tell us a little bit about the survey that you conduct of the healthcare providers in the state?
Yeah, absolutely. So we conduct a survey of the Minnesota licensed healthcare providers all the time. So this podcast, I know, is about the specifically about our COVID survey, but just to give a little bit more background, several decades ago, the state legislature mandated that Minnesota collect certain bits of data on all licensed healthcare providers for the purposes of workforce planning. The survey that we conduct at the Department of Health is actually part of the documentation that all providers have to complete when they're renewing their professional license. Mm-hmm. And the purpose and the reason why the legislature considers it so important that they make it a mandatory part of having a professional license is so that MDH can gather the critical data that the state needs in order to do workforce planning. You know, all industries do workforce planning of some sort or another. Mm-hmm. But one of the reasons it's so important that the healthcare workforce is well studied and well documented is because when you have, say, a shortage of, electricians or plumbers, that can be serious. You might have to wait for a plumbing issue to be resolved or to have an electrical job worked on. But when you have a shortage of healthcare providers, that can be really a human rights issue, really, affect access to care. And so it's just so important that we have the right force data in order to plan, to anticipate, and to adapt to changes in the workforce.
So can you tell us a little bit about how the data might get used? Any insights you can offer?
Yeah, absolutely. So our data is an input to so many different initiatives that our own office does. For example, gets used as an input in our loan forgiveness program, in our, different legislative task forces, our Rural Health Advisory Committee, and just generally kind of how we make decisions about, where to put resources into the state workforce. We also share the data with institutions of, higher education who are making plans about whether or not to expand a particular program and where. We get a lot of media requests, which sometimes, just into kind of the popular discourse. And so the data gets used that way.
So you had recently conducted a survey of providers to understand how this pandemic has impacted them. So I'm really eager to hear what you've learned.
Yeah. So starting in March, as Minnesota was really just beginning to report some of its first known cases of COVID, we had a pretty good sense that there would be a shock to the healthcare system. Work would really change dramatically for a lot of healthcare providers in some ways that maybe were sort of predictable, but in other ways that were very much unpredictable. And so we wanted to use our survey as a way of kind of understanding what was happening. We very quickly created a really short, kind of COVID-specific version of our usual license renewal survey, which then we put into the field. We asked questions about a variety of things. So we had started to hear anecdotally about layoffs and clinic closings and providers moving to telemedicine, and just wanted to get, a handle on how widespread all of this was in Minnesota. So we fielded the survey in May and kept it in the field through August and collected responses from just over 33,000 providers.
Oh, that's great.
And the survey included physicians, mental health providers, nurses, respiratory therapists, and physician assistants. And I should mention here, we didn't have an opportunity to get responses from dentists or other oral health providers, nor did we collect data from pharmacists or pharmacy technicians because they renew at a different time of year. So we couldn't include them in our sample.
So what are some of the main takeaways? What did you find in your survey of these providers?
Well, we really had quite a number of interesting findings, but I think for today, I'll just focus on what I sort of have been thinking of as the three biggest ones that really impacted us. I'll just mention each of these briefly, and then hopefully we will have time to talk about them each a little bit in more detail. One thing that's become really clear from our findings is that in terms of its impact on the healthcare workforce, the pandemic it's not a one size fits all. What I mean by that is that different provider groups have really had different experiences when it comes to layoffs and reduced hours and pay cuts. On the flip side of that, they have different experiences working, more hours. Some provider groups are working more hours really than ever, and others have been laid off or had their hours reduced. The second finding is just how quickly providers and systems across the entire spectrum of healthcare have adopted telemedicine. The transition to telemedicine, which, we were seeing sort of the beginnings of that over the last decade. It probably would have happened anyway over the course of the next several years, but it happened at absolute lightning speed during 2020. And then the third major finding, it has to be said, it has to do with the absolutely immense strain that this pandemic has placed on what is really an already very stressed system, very stressed workforce. In a way, this is obvious. We all see signs thanking our essential workers, thanking our healthcare workers. So I think at some level, everyone understands what a difficult job healthcare providers have right now. But what I'm seeing in the data really has some potential for some alarming consequences, and particularly in rural areas that I think it would be to our detriment to ignore.
I'd love to unpack these one by one and hear your thoughts, Teri. So tell me, what do you mean when you say that the effect of the pandemic on the healthcare workforce isn't one size fits all? How has it been uneven?
Overall, we know that during the survey period, over the summer, roughly 4% of licensed healthcare providers in Minnesota experienced either a temporary or a permanent layoff as a direct result of COVID. But then this varies really quite a bit when you look across the different provider types and across regions. So, for example, most mental health providers were fairly insulated from layoffs and had layoff rates around, 1% to 3%, depending. And that was the same for physicians and for registered nurses.
Okay.
The group that really did not fare very well was physician assistants. So we're seeing that just over 10%, 1 in 10 of all Minnesota physician assistants experienced a layoff as a result of COVID. And that's 300 providers. So that's a really huge loss.
And why do you think that the physician assistants were particularly vulnerable to layoffs during this pandemic?
Yeah, it's hard to be 100% sure. But I think the main reason probably has to be that physician assistants by law, or at least up until May of 2020, by law needed to be supervised by a physician in order to practice. So since they can't practice or they couldn't practice without physician supervision, that leaves them quite vulnerable if a clinic or hospital is just trying to cut jobs.
And so are there any differences in how, let's say, the Minnesota physicians fared as compared to their counterparts nationally? Are you seeing anything same or different there?
Yeah, actually, we have a little bit of a bright spot here. So the Minnesota physician assistants are doing quite a bit better than physician assistants are doing nationally. So Minnesota, we have about a 10% layoff rate, whereas nationally, according to a survey done by the National Association of Physician Assistants, the layoff rate is about double that at 20%. So that's really pretty high. So we're doing quite a bit better here. And then also I can add another bright spot for PAs, and that's in rural areas where actually we're seeing a layoff rate of just under 5%. So, even half of the statewide layoff rate. So that's good news as well. On the other hand, we have bad news, good news for physician assistants. While physician assistants are doing relatively well in rural areas, the same is not true, unfortunately, for rural physicians. So what we're seeing for rural physicians is that they are about twice as likely to have experienced a COVID layoff than urban physicians. So if you look at physicians, regardless of the type of medicine they practice, less than 2% of urban physicians experienced a layoff, whereas 4% of rural physicians did. That's a small number or a small share. But the other thing that has me a bit alarmed about our rural physician workforce is looking not just at layoffs, but also at retirements. Just to provide a little bit of context, to be clear, we always see some share of providers in our survey indicating that they're retired. That's just kind of every single year.
Right, you'd expect to see that.
Yeah. But during this period of time, during the COVID survey, 11% of rural physicians reported that they were retired, compared to 6% urban physicians.
Okay.
Higher than what we've seen in past surveys. So, we've always known that our rural physician workforce is aging. We've always kind of been keeping an eye on that population of providers because, we're expecting layoffs. But what I'm concerned about and what the data is sort of pointing to is layoffs that have been prematurely ushered in by COVID. We are hearing about this from some of our work groups in the Office of Rural Health and Primary Care. And the data is pointing to this possibility that, maybe these physicians might have worked another, year or two or even 5, but have just decided, well, maybe this is a good time to retire. So that's a concern. And now, again, we're talking about relatively small numbers. So, you don't want to overstate things. But on the other hand, what we really have to keep in mind is that in rural areas, rural Minnesota and rural America more generally, we're already struggling with shortages of physicians, and we really can't afford to lose even a small number. In rural areas, small numbers count. So if you're looking at a county or a region that has just, 1 or 2 family physicians, and that family physician or those physicians are laid off or decide to retire, that one change could have a really outsized effect on access to healthcare in that region.
The implications of these findings are certainly grim. And I'd love for us to come back and talk a little bit about what we can do about all of this before we close. But thank you for raising this issue. So you talked about the unevenness of the impact of COVID on the workforce. Can we also quickly turn to learn more about your findings on telehealth? We often hear that telehealth is that silver bullet that's going to solve all of our access problems. Is that what you're finding in your survey? Is that resonating with you?
So before the pandemic hit, the use of telemedicine among providers in Minnesota, as well as nationally, was really not particularly widespread. So when you think about the pervasiveness of telemedicine, think about 2 things. Think both about the share of providers that are using it, and then the amount that each provider is using of it. If every single provider in Minnesota uses telemedicine, but they only use it for very, very limited circumstances, or, say like once a year or something like that, that really won't account for very much care being provided by telemedicine. Likewise, if you have just a very small group of providers using telemedicine, and even if they're using it quite a bit for a large share of the care that they're providing, that's still not a lot of access provided through telemedicine. Before COVID hit, based on our survey results from the calendar year of 2019, we know that across the board, about 1 out of 4, 27% of providers reported ever using telemedicine. And more than half of those saying that they used it really only once in a while. That wasn't a lot. And we saw those numbers, moving slowly, increasing just slowly each year. However, during the COVID survey, what we see is 35%, so over a third of providers reported using telemedicine. That's a very modest increase from the 27%. But the really interesting thing here is how much they're using it. So among those providers who are using telemedicine, about half say they're using it for at least half of the care they provide.
Okay.
Nearly 1 out of 5 are saying they're using it for virtually all of the care that they're providing. So that's a gigantic shift just overnight.
And why do you think that is the case? What do you think has prompted this?
It was about survival. So for a whole lot of providers, they had no choice. Forced providers to do in a matter of weeks what otherwise might have happened, again, like I was saying, over the course of several years or longer. I think mental health and some primary care and even some specialty care, the option was to move to telemedicine or just close down. So most providers moved to telemedicine. Mental and behavioral health providers were the group that was most likely to adopt telemedicine. In our survey, more than 60% of these folks were using telemedicine, and the vast majority of them were using it for most or for all of the care that they were providing. So really, mental health has shifted to telemedicine almost entirely.
Exclusively, yeah.
Yeah. Physicians were also quick to adopt telemedicine. About half of them reported using it, but the share varies a fair amount when you look at different specialties. So, and perhaps not surprisingly, psychiatrists were the most likely to pick it up. Almost 2/3 of all psychiatrists reported using it. And then family medicine and OBGYNs and pediatricians also made the switch very quickly. There was not a single provider type that was not using telemedicine. Every single provider type reported using it, at least some. Some of them, like nurses and physician assistants, were using it far less frequently. And I think this probably just has to do with, the nature of the work that they're doing. So people who are working in hospitals or providing critical care, just not in a position to use this modality, on a regular basis.
So it's clearly been a success. The telemental health model seems to have been a success. Do you have any insights into what the providers think of this modality? Like, how's it going? Has it been successful?
We did ask some questions about how, their feelings about it and how effective they thought it was. And we're learning some good nuanced information. So what we're hearing from providers is that it's a great tool for, follow-up care, for things like medication checks, refills, mental health visits, and just routine appointments. It's not a great substitute for in-person visits, for conditions that might require, an in-depth physical exam, like heart disease or lung disease or more complicated problems. Providers commented that it can be a great solution in rural areas or for people who have to drive a long way to get in to be seen. But then, the flip of that is that the lack of broadband can create access problems in those areas as well. They also mentioned it's not so great for patients who lack the technology or who have trouble mastering the technology. So that can include, some low-income patient populations, seniors, and a number of providers mentioned that telemedicine really doesn't work so well for patients for whom English isn't their first language. It seems that telemedicine solves some problems really quite well, but it also exposes some of the same inequities that we're always grappling with in public health.
So do you think it's here to stay, or is it just, sort of the flavor of the month, it's a temporary fix and we'll be on to different things once the pandemic is behind us?
I think it's pretty good evidence that it's here to stay. And you really, you don't have to be a researcher to realize this. The longer the pandemic goes on, the harder it's going to be to go back to the way things used to be. This goes for just anybody in normal life, as time we're getting used to working from home, wearing masks, social distancing. And likewise, I think as more and more providers adopt telemedicine as a modality, they will have just gotten used to it, to some of the convenience, and will probably, and I think not only will the providers be used to it, I think patients will also be used to it and will probably appreciate some of the convenience of accessing a physician or a nurse from their living room. That's just impressionistic, but we have some data that bears this out pretty strongly too. Among the providers who are using telemedicine, almost 90%, so 90%, that's huge, said that they plan to continue using telemedicine at least some of the time once the pandemic ends, a huge jump from where we were a year ago. So my hope is that as we move forward from this, we will be able to use some of the findings that we've gathered from this survey to make smart investments about telemedicine and about when it works well, and then hopefully, figuring out how to make it work better in those places where maybe it needs a little bit of extra help.
Yeah, or refining.
Yeah.
So let's move on to the last major finding from your survey. I'm eager to hear about what providers have to say about how this pandemic has really impacted them. What are you seeing in the data related to this?
Yeah. Oh, absolutely. So I think this is a really important topic. I'm glad to spend a little bit of time on it. I just sort of want to contextualize this by talking a little bit about where we were in terms of our healthcare workforce a year ago, before the pandemic hit. So even under, very ordinary circumstances, we were demanding quite a lot of our healthcare providers. Healthcare delivery has been changing really rapidly over the last 5 years, and it's placed quite a strain on the healthcare workforce. There were already workforce shortages, so they were already working long hours and struggling to find work-life balance.
Mm-hmm.
So, and this was having some pretty serious implications. We were, seeing in our data that we're losing providers to burnout faster than we otherwise might. Every year, we lose about 1% of providers to burnout, or, double that, 2% in rural areas.
Okay.
Again, and I feel like a broken record in a way, but 1 or 2% is a pretty small share. But again, if you're talking about a single physician or a single advanced practice nurse in a county, in a small town or rural county, that has an outsized effect. So that was a year ago. Now, as we're in the COVID period, the pressure and strain on our workforce has just grown exponentially. And this has some of us at the Department of Health really concerned for the future of the healthcare workforce.
So what are some of the added stressors that you're hearing about as a result of the COVID pandemic?
The single most common concern among our providers is that they themselves will contract the virus and get sick or bring it home.
Sure.
And we didn't just hear this, a dozen times or 100 times. This was the comment that we heard several thousand times.
Okay.
All provider groups. So along with that comes concern over the lack of adequate personal protective equipment, or PPE.
Mm-hmm.
Many providers report being frustrated and angry that people aren't taking the virus seriously or aren't practicing social distancing. And many just report feeling overwhelmed and burned out and say that they're having to do more with less. And one thing that came up quite a few times is that they're seeing patients who are sicker, whose conditions have become more acute simply because, they've avoided going to the doctor for normal problems.
I see.
Of, contracting the virus. And so by the time they actually get in to see their provider, they already are looking at, more difficult diagnoses. What I'd like to do here is, I think that the providers themselves can probably share their stories more eloquently than I can. So if it's okay, what I'd like to do is just read a few quotes from their responses.
Yeah, I'd love that. Please go ahead.
Okay. I have a set from, kind of a smattering of different provider types. And each one of these provider types has, a slightly different lens. Here's a quote from a respiratory therapist who says, "Our hospital still does not seem to have the proper amount of PPE since we are reusing N95 masks. They're keeping track of the amount of PPE or masks that we're using too. Due to furloughs, we now seem to be understaffed and it is unsafe, all on top of getting a pay cut." Now, a physician takes a slightly different view of this and says, "Our current healthcare model is too highly dependent on elective and non-emergency procedures, both outpatient and inpatient, for its financial survival. This has led to many furloughs and decreased opportunities for part-time workers across the system." Then an RN says, a registered nurse, and this sentiment was very common among registered nurses, "My concern is the possibility of myself or my family becoming gravely ill due to the fact that I enter straight into a hospital 3 days a week that cares for COVID patients. I believe we healthcare workers are more than deserving of a monetary bonus for this, just as other businesses have done. I'm working too many hours to collect unemployment and too few hours to pay my bills." A social worker says, "My job security seems very vulnerable. Although I'm still doing a needed job, my employer has been losing so much money that I fear my job will be cut." And then finally, a comment from a licensed practical nurse, many of whom work in long-term care facilities and nursing homes. This person says, "Keeping my residents and staff members safe is my biggest concern. Many residents do not seem to understand why their loved ones aren't there to see them. So helping them to understand why, which at times is not easy, and to reassure them that they have not been left."
So what do we do about all of this, Teri? Like, how should we as a state respond?
That's the million-dollar question. One answer is that our office, the Office of Rural Health and Primary Care, is exactly set up to respond to these challenges. I mean, this is what we do. It's our bread and butter. So we have a whole variety of programs, of grants, of loan forgiveness programs, work groups, technical support programs. They're all there to provide assistance, funds, and support at all levels to the healthcare workforce, to healthcare systems, to communities. So part of what I want to say is just, we should continue doing the work that we do. An example, though, of an area where, we've tried to specifically address some of these issues, some of these problems that we're seeing through COVID is in our emergency grant program that we've been managing through the pandemic. Our office has dispersed over the summer. Our office dispersed $200 million worth of state funds directly out to clinics, hospitals, systems, tribal organizations, offices, mental health providers' offices to fund COVID-related needs like the cost of testing and PPE and overtime for staff. We're sort of fighting the battle as it's happening. Another thing I would say is let's, as someone might say, don't let this crisis go to waste. Let's really learn something from it. So our office, in our state in general, is really quite good at pivoting and shifting and reprioritizing based on solid evidence. So, for example, now we have a pretty good idea, a much better idea than we used to of the conditions under which telemedicine works and doesn't work. So let's use some of this intel that we've gathered to support smart policies and investments. And let's be proactive about shoring up our workforce, particularly workforce, so we're better prepared for the next crisis. Sort of my final big picture thought is this. Let's take a big step back from all of this and look at it from a broad perspective. The pandemic has really underscored the critical role of public health in healthcare. These just can't be uncoupled. So I think systems, payments, incentives all have to be responsive to that. We really need to work to cultivate a culture of support for our healthcare providers and to cultivate workplace resilience.
Teri, thank you so much for joining us today and for sharing all these insights. For those of you interested in learning more about some of the initiatives that Teri mentioned or want additional data on this topic, please visit health.state.mn.us and type COVID survey in the search box. That'll give you a host of additional resources. On behalf of the Minnesota Rural Health Conference hosts, I would like to thank all of our listeners for tuning in. To access the other podcasts in this series, click the link in this podcast description or visit our conference website at minnesotaruralhealthconference.org/podcasts. We hope you are celebrating the power of rural in your community. Happy Rural Health Day, everyone.